Okay. Next slide. So most people, I think, right? Although there's been some reluctance because you're donating to someone you don't know, and you're receiving a kidney from someone, your recipient's receiving a kidney from someone you don't know. So you've lost control, the donor loses control of their kidney or where it goes and how it's treated, and you're also getting a kidney from someone you're not sure about.
Dr. Melcher, you might
Yes.
want to have hands raised in this room of people who've had that kind of donation. I mean, we may be the only, well, we're not.
No.
Oh, you're not?
There are 2 couples in the room at least.
3 couples. If they want to.
So.
Yeah. So that, a simple A, B, B, A is straightforward, but you also can have, remember, if you, next, O is a universal donor, except when the recipient is sensitized to that O. So this recipient has antibodies against that person's tissue. So next, they're sensitized next. So in each of these cases, the cross-match is positive. But what you can do is cross-match this O with this A, and it may be that they're compatible now, and this pair may be compatible. And the HLA, there's 6. There's the 6 loci, right? And there's several different antigens can be at each loci. And if you have many patients in your list, you can see it becomes sort of a computer problem, computer analysis problems to maximize the benefits of people. And Dave Jacobs here has actually put together some software that facilitates that they're using up at CPMC. Next. So now this is a little bit different. In this situation, you have potential donors and potential recipients. Stop. And this O can donate to this A. This is a universal donor, can donate to this A. And let's say this A is not even sensitized. But let's say you have another pair where the donor wants to donate to this recipient, but this A cannot go to an O, right? Because O's can only receive from O's. So this couple is stuck unless you do a paired exchange with them. Now remember, these people know each other. They could go ahead and get the surgery. They can get a transplant, and they'd be fine. But if they're willing to work with these pair, both pairs could get transplanted. Now, how many people would be willing to do that? Is there any reluctance? I mean, there's sort of a. I mean, maybe this is the wrong audience to ask, but
there's more to say about because potentially.
Well, that's the next step, right? But first, right. So if that was if it was just an even exchange, that I think there's some reluctance in the public, I think, to go this way.
So is it a standard procedure to have the paired recipients contact the paired donor should they want to?
No, we actually discourage any contact until after the transplant, and then we make sure everybody in the group is willing to communicate. Yeah. Well, if it doesn't work, they're free to contact. I mean, I wouldn't. But provided the match takes place, you mean, or the transplant takes place? Right. So we encourage it to take place after the transplant, because if you find out you don't like the person you're giving your kidney to or something, I mean, we don't want it to fall apart like that. But in another sense, I mean, I'm not sure what the ethics are. If everybody wants to meet ahead of time, I'm not sure it's my place to stop it either. So, but generally, people don't necessarily want to meet ahead of time. Most people, I think, do afterwards, but not everybody is. I mean, the people who've gone through it can talk about that, or maybe save that till later and talk about that.
But Mark, back to the compatible pairs. I mean, there's the overall benefit, the medical quality.
So Dave is talking about is first of all, the benefit of using compatible pairs in a paired organ exchange is you get 2 people transplanted instead of just 1. But there could also be a benefit to A. For example, let's say this donor is a little bit older. And this donor is younger. So by making this cross-match, this recipient receives a younger donor and a kidney that may last a little bit longer. And this patient gets a kidney transplant. So a little bit older donor, but at least they get off dialysis.
Or they could all be better. They could be better BMI. They could be better matches.
Right, and the HLA matching can be better, or size matching can be better. Yeah.
It's not excluded just to a 2-way. It could be 3, 4, or other benefits of it. So. And in a pool, you get 50 to 75% more matching when there's compatible pairs put into it. So overall goal is benefit.
Right. So yeah, there's published, people have done lots of mathematical models of this, and I think if you include compatible pairs into your paired organ donation program, you increase significantly the number of matches you can do. But you sort of have to get over that hurdle of, you have to basically approach these people to see if they're willing to do this.
Have you ever thought about asking donors who come in with needing recipients if they would be interested in participating in paired donation rather than just donating to their designated recipient?
So at our point,
Be proactive about it?
So we haven't made the decision that we're willing to go that way yet. I am, but I have to. Not everybody is willing to. And it came up recently in discussions about specific patients and stuff, but we haven't done that yet.
But Mark, am I correct that if there are compatible but significant mismatch needed, just BMI, that's something you might consult about? Or if it was a BMI mismatch that you wouldn't do?
So we are getting the regular pair donation working first, and the swapping first before we go there, basically. So we haven't done it yet, but it's on my agenda. So another variation of this is something that Johns Hopkins has done, where they take a non-directed altruistic donor. So these donors, all the donors are altruistic, right? But this donor is, we call it non-directed altruistic because they're not getting any benefit and any partner or friend getting transplanted because they're donating. They're purely donating to the list. And by using that altruistic donor, they were able to start this domino of swaps where this O donated to this B, this parent donated to another spouse who donated to so forth, and then the final donation went to someone on the deceased donor list. So it's a very nice situation where you get 4 patients who've brought potential donors to the table, and 1 patient who's been on the deceased donor list gets transplanted also. Next. And then the next variation is donor chains, or another term that you might hear in the news is never-ending chain. And this also starts with a non-directed altruistic donor. And everybody who comes to the table here, all the recipients that come to the table do bring a living donor to the table, incompatible, willing, healthy, living donor to the table. In this situation, we have this non-directed altruistic donor give to an A B give to a B, A give to, I guess this is it must be an A, and then you have this donor who's left over. We call this the bridge donor next. We call this patient the bridge donor, and they can go on to the next slide. They can go on and start another cluster. So we call these sort of clusters of transplants, and this can go on because now we're left over with another donor here, and that can start another cluster of transplants. And you can decide, maybe after a while, you want this bridge donor to donate to the deceased donor list so the deceased donor list doesn't get neglected. And that's a matter of debate, actually, in the field right now. One of the ways to make this work well is to make sure this patient can donate to as many people as possible. So if you get down here and you get it's an AB at the end, that AB is not very powerful, right? Because they can only donate to other ABs. And most other ABs can receive a kidney from anyone. So there aren't going to be many ABs on the table. So you really want to have your software program maximize the ability of that bridge donor to donate to other people. Go back. Back forward. Okay. So the other thing of discussion always, and that we're always trying to decide, is you can use various algorithms to which matches do you prioritize in these donor chains? Of course you prioritize blood type and maybe HLA matching, but then also there's a sort of sense that you need to be equitable to everybody involved. So in terms of match compatibility, you might want to match age. You don't necessarily want to give a 65-year-old kidney to an 18-year-old recipient, right? So to maximize the whole system, you try to have an equitable situation.
What's your age distribution? Your policy on the donor, the senior of the recipient?
So it depends a little bit on the relationship. So if you have a parent donating to a child, we may allow that where a friend who's the same age as that parent may not be able to donate to the child. But then a lot of it goes back to the medical physiology of that donor. So we've had donors who are 65 or older who are incredibly physically fit, you know, and their kidneys we thought was suitable for someone significantly younger than them.
Is it like a 30-year, the junior, or what's the range that you try to keep under?
I don't think we have any hard and fast guidelines. So.
Obviously, the younger kidney's not as much of an issue as the older one.
Right, right. Okay, next. And then, so we did a donor swap here at Stanford and CPMC a couple months ago now, and we actually got some good press. I couldn't resist to put a portion of the TV news coverage on it. If you hit go, and this is basically explaining where all the kidneys went and came from. We don't have sound. Sorry.
Do you want to try the speaker?
Do you hear it?
No.
No. Well. Yeah, it didn't work.
It didn't work. Didn't work.
Basically, the news reporter did a very good job of explaining it. But a kidney came from a bridge donor at UCLA and was donated to a recipient at our hospital. That recipient's wife donated a kidney that went to Cornell Hospital, and the spouse of that patient donated a kidney that went back to CPMC and went to a patient there. Now there's a leftover bridge donor at CPMC that potentially would donate into the future and start another cluster.
Do you fly the kidney from across country?
So that's something we did. It was a little bit different here too. So we had 3 kidneys all in the air at the same time on commercial flights.
Why don't you, I mean, it seems to me that given the risk, it'd be worth a few $100s to fly the donors instead of with the kidneys before you...
So it's interesting. So in the program that this was done in, when you register the donors, most of the time when they're registering, people say, yes, I'm willing to fly anywhere to get my spouse a kidney. When it actually comes down to it, most people really want to be in the same hospital as their partner or spouse is. They really don't want to be across country and have one person getting an operation in California, one person getting an operation.
When you're both in the hospital at the
Right,
same time.
right. And so in reality, it sounds like from a distance, it sounds like it's the way to go. But in reality, people really want to be together. And if we're going to make this a national program where it happens on a consistent basis, I think we're going to have to accept shipped kidneys. We ship kidneys all the time when we have deceased donors. But you're right, it adds significant ice-cold time. And I think the longest cold time here may have been about 12 hours.
12 hours of
Ischemia time, yeah.
Wow, that's great.
So, but I think by doing this and proving that it's doable with commercial flights, and deceased donor kidneys are often transported on commercial flights also. By doing it, it's in terms of the pragmatics of making this program work on a more national basis, I think is the way to go. I mean, but of course, if the donors are willing to travel, it's better. It's better. Okay. So we've talked about these issues already. There's the ethical issues of making the appropriate match, of making sure that the donor who's donating to a paired donation knows that they're going to lose control of that kidney, that the recipient of his or her kidney may stop taking immunosuppressant medications in 6 months. And they sort of have to be willing to let go of that. There's the ethics always of doing living donors. You know, like I said before, those donors are at risk, and I really think the donors are real heroes and can't be under-recognized in this whole process. I always hesitate to make people reveal their medical histories. So if people want to volunteer who donated a kidney, raise your hand. So we have several here. That's great. There used to be illegal issues because there is the National Organ Transplant Act of 1989, basically, that was actually pushed through by Al Gore and Oscar Salvatierra, who's one of the retired surgeons at Stanford. said that it was illegal to sell organs or exchange something of value for organs. And if you're exchanging your kidney for their kidney, that is obviously exchanging something of value. So a lot of people were hesitant to move forward with these paired organ exchange programs, even though it sounds silly, but we all have these lawyer fears. You know? So excuse me for but luckily, the Justice Department and then Congress, Justice Department sent out a memo that basically said they weren't going to pursue any cases like that. Then Congress passed a modification of the act, and then Bush signed it. So luckily, the legal issues are over with. Logistically, it can be a nightmare. You have basically 6 operations going on at the same time. So if any one person gets sick, you know, that cancels basically all 6 operations. If they happen in the same hospital, you need to have 3 to 6 ORs available all at the same time, and 3 to 6 anesthesiologists and enough surgeons, for example.
But in the Bay Area, you've got 3 of the top hospitals in the world within 30 miles of each other.
Right. So it's very easy to, and you don't have a lot of cold ischemia time, so there's no kidneys in the air. Right, right. It'd be quicker than going to Cornell. You're right. Ethics, I've talked about this already, so we can go further. Okay, so I've talked about paired organ donation and paired chains. Let me go to desensitization very briefly. Again, there's the issue that next of having these antibodies against the kidney and having these antibodies in the recipient against the kidney donor that you're receiving. So the key is to get rid of those antibodies and get rid of your body's ability to make those specific antibodies. So go back. Okay, so this process involves plasmapheresis, something else called IVIG infusion, and possibly anti-T cell therapy. So it's a very involved process that takes place over months of time period and multiple blood tests. So we're constantly testing your blood to see if you're compatible with the donor that you brought forth. Stanford, there's a few places in the country that are doing. Hopkins is doing it, Cedars-Sinai is doing it, and we're doing it at Stanford now. And we're using mostly patients who are highly sensitized. So if you are 100% sensitized, or a PRA of 100, you basically don't have an option of doing a paired exchange. You have to be desensitized to be able to get a transplant. Okay. So basically, if neither of these work, I mean, if these work, you get a sexual transplant. If neither of these work, unfortunately, you have to come back to the wait list and wait your time. Next. Yeah. And time, and next. So now I'm going to talk a little bit, just briefly, about extended criteria donor. This has come up. If you hear the term ECD, that's what this is. The extended criteria basically are kidneys that previously would not have been used because the risk of them not working was too high to take on your patient that's been waiting for 6 years for a transplant. However, some of these were used and people started becoming more aggressive, and a lot of them actually worked. So next. Briefly, just to define what they are based on the UNOS criteria is that all deceased donors that are older than 60 are considered to be ECD. And if you're between 50 and 59 and you have 2 of the following criteria, one caused by a stroke, death caused by a stroke, history of high blood pressure, or terminal creatinine of greater than 1.5. And that's based on taking a large amount of data and looking at the outcomes of these kidneys. What's the benefit of taking an ECD donor? One, if you're an O blood type, you might be able to get an ECD donor in 4 years instead of 8 years. So it might cut your wait time in half. It's a little bit like, playing the stock market, though. You can go for the risky stocks, the Google or something, and do really well, or you can go for the risky stocks and not do so well. So for us, we really need to make sure that the patients are fully informed of the decision they're making, and that they understand that if they're taking ECD, they're at a higher risk of the kidney not working. That being said, at Stanford, we're very conservative about what ECD kidneys we take, and the numbers at Stanford have been very good for the patients that we've actually given ECD kidneys to. Yeah.
If it's an ECD kidney with a creatinine of 1.5, does that pretty much guarantee that it will stay at 1.5 or higher after post-transplant?
So it makes it more likely. It certainly doesn't guarantee it. So if that comes from someone who's 200 pounds of muscle and it's going to a petite person, it's likely that that kidney will work great and get their creatinine down. Yeah. So you can sort of calculate an estimated clearance of where the kidney is in the donor and then calculate what you think it might be in the recipient. It's not always easy to predict, though. But basically, I think, yeah. Basically, this is already brought up before. Basically, the guidelines we have, or that are national guidelines for this, are if you're over 60, it makes sense to accept an ECD donor for the most part. If you're over 50 and have diabetes, it also makes sense to, maybe even over 45 and have diabetes. We tend to be over 50 in diabetes do we start offering ECD donors to patients. It goes through a formal consent process. You need to consent to it, signifying that you've had the conversation with the nurses and the doctors, that you understand that there is a slightly additional risk. But I think, like I said, under those criteria, people with diabetes above who are older than 50 and anybody over 60 probably benefits from getting an ECD donor. Okay. Great. Next. Okay. So then if you don't get an ECD donor, there's more wait time. And then you're waiting for when you start coming up to the top of the list, you're waiting for a compatible donor. And next. So we often will get a call in the middle of the night saying that we have a donor available for patient X. Do you want to accept it? Things we ask are, well, make sure it's not an ECD donor at this point. Make sure that the age is appropriate for our donor, so we won't give a donor that is 59 years old to a very young recipient necessarily, unless it appears that the kidney function is perfect. We'll look at size mismatches. We'll look at how that patient died, what they died from, and the latest lab results are very important to us. And then we try to decide whether or not it's a good match for you. And then hopefully we can go forward with a successful transplant. Other issues at that time are, is the patient ready? Are they in town? Are they nearby? Are they sick? Have they had their complete workup? So like their cardiac, make sure that their heart is in good shape, their lungs are in good shape. Because sometimes it'll be several months or even a year since we've seen that patient last. So we want to make sure that patient is still ready for transplant. And then we have to make a decision. Would that patient, now they've been waiting for 8 years. You don't want to give them a kidney that's not going to work, right? And that's become more and more an issue as that wait list has gone long. So we really want to make sure that we're giving them the best possible organ for that wait time. We have to balance that, of course, with all of society getting kidneys too, right? So we can't throw away kidneys.
Are all the donor transplants tested for diseases?
So there's a standard panel of diseases, including hepatitis, HIV, CMV, Epstein-Barr virus that they are tested for, yeah.
How about rabies?
That's a very good question. I don't think it's a standard test yet, but that may have changed since several well-publicized cases in the last 5 years.
Cancer? Donors that have had cancer accepted?
Yeah, so if they've had recent cancer, certainly not. The question becomes if they've had cancer 15 years ago, breast cancer or prostate cancer or skin cancer. And that becomes, it's up to the receiving surgeon to make that decision and a conversation between that surgeon and the recipient.
But they really can't do too many biopsies on the organ because you don't want...
No, even but if they have a history cancer, you can't, it's hard, if someone comes in never diagnosed with cancer, they may have a small cancer somewhere that you won't necessarily find. You can't find, because you can't biopsy every organ to determine that.
Just a question on the age, not age, I'm sorry, weight mismatch, or donor size. What is the criteria roughly, and how does a mismatch in donor size affect the longevity of a organ?
Right. So let's say you have a very petite person, 100 pounds, has a creatinine that's sort of borderline. Maybe they died of a stroke, they have some cardiovascular disease, and they're borderline creatinine 1.5. I'd hesitate to give that kidney to a muscular 200-pound person, because that kidney is probably not going to adequately function for that patient. And there's probably, that kidney will have a shorter total life expectancy than it would if you had, it has less reserve than a patient, than if it came from a much larger muscular patient with the same creatinine. And I can't tell you any exact numbers or criteria that we use. I mean, if the recipient is more than 50% larger than the donor, I start getting concerned and look at it more carefully.
What about high blood pressure or kidney stones for the donor?
So in terms of living donors, that becomes relevant. So for living donors, we don't like to take living donors who have a history of high blood pressure or diabetes, because those patients are often, those are two diseases that cause renal failure. So we don't want to take a kidney away from those donors in the future. For kidney stones, it's a similar thing, but it works both ways. We don't want the recipient necessarily getting kidney stones. And if we take away one of your kidneys and you have a history of kidney stones, if you get a blockage in that remaining kidney, that one kidney is at risk of you losing it. So we're reluctant to do that. We have taken cases where we do use donors with a history of kidney stones, but we make sure everybody's fully informed of the situation.
I got one question for you. Well, in this world of genetics now, maybe the donor doesn't have a history of diabetes, but you can see that there's an antigen that might be associated with the future with diabetes. Would you transplant that, or would you be concerned if there's no history and you saw the HLA? Because certain things are associated.
I'm not sure that's a good example, because I don't think there's any one antigen for diabetes that proves it. But in the future, there might be. And
well, there are groups that could be.
Right. So we do take patients who have no family history of diabetes, even though they're in high-risk groups, for example. Yeah. But it's on a case-by-case basis. And the important thing, I've said it over and over again, communication between the doctors and the nurses and the patients is very important in this situation. And self-education is very important in this situation. And setting expectations.
What about donors with a history of high solvent use? I have a potential donor who's an art restorer and works with terrible solvents all the time. And I have another one who's in the construction industry, and he works with paints and epoxy.
So we do pretty extensive lab testing on patients, on all patients, and if any of those things have caused any damage, I think we'd pick up a lot of that on testing. So if the creatinine was perfect in those patients or close to perfect, I think it'd probably be acceptable, barring other issues.
Am I correct in assuming that in order to get into the pair exchange program that you have to present a donor, a living donor volunteer that is not compatible?
Correct. Okay. Correct. Right. Do I have anything more? It's just so if you hear terms, and actually this has been in the news, unfortunately, in the last year, donation after cardiac death, or otherwise known as DCD. So we talked earlier, but someone asked, what is a deceased donor? So like was said, most of the time a deceased donor is somebody who's brain dead. So their heart is still pumping, but they have no blood supply to the brain. They have no reflexes, basic reflexes in the brain or the brain stem. They don't blink. There's no gag reflex, et cetera. There's very explicit criteria set forth by a consensus committee back in the early 70s on what defines brain death. But there are situations where a patient is technically still alive, still is not brain dead, because they may be blink or they may have a gag reflex, but of course there's no thought process going on. And the family's been told by the primary doctors that there's no hope that this patient is ever going to achieve a meaningful life again, or a quality of life again. So that family may decide to withdraw care from that patient. In that situation, they withdraw care, and eventually, so they take him off the ventilator, they don't give him any cardiovascular medications, and that patient basically stops breathing and their heart stops. At that point, they've now can be declared dead, and then their organs can be used for transplant. Okay? In that situation, those organs theoretically not quite as good, because there's a time period after you withdraw support where the patient's blood pressure and the heart are not working very well before the patient expires. So the patient's organs may not be getting a good blood supply, good oxygen supply, and may be actually injured while this process is taking place. It usually takes place in the operating room, and it's a very tense situation because someone is actually dying in front of us, or in front of the primary care doctors, and obviously the staff, everybody around, that doesn't feel comfortable in those situations. But after the patient is declared dead by another doctor, we come into the room, or the procuring surgeons come in the room and rapidly extract the organs, perfuse them with preservation solution, and pack them on ice as fast as possible, such that those organs are now usable for someone else. And the evidence generally is if that donor is less than 40, those organs are as good as standard donors. If that donor is older than 40, there starts to be some differentiation between those organs and other organs of the same age. And that's what I say here. So that's donation after cardiac death, if you hear that term.